Good evening, doctors. My name is Ankur Gautam, and on the behalf of MedTalks and FDC, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Friends, today's topic is very interesting topic, diabetes and thyroid. But before moving on to the topic, I would like to announce the last week winners, quiz winners. Dr. Rajiv Handa from Delhi, Dr. Anand Purande from Mumbai, Dr. Ravi Bhatt from Sirsi, Dr. Bharat Praveen Mittakota from Surat, Dr. Ashutosh Das from Tamluk, Dr. Kaval Saluja from Mumbai, Dr. Shashi Khare from Bhopal, Dr. Ramesh Hegde from Bangalore, Dr. Surjit Kalsi from Noida, Dr. Jagdish Shah from Mumbai, Dr. Suhas More from Pandharpur, Dr. Vilas Sunamane from Ashti, Dr. Ashwini Kumar from Kanpur, Dr. Umesh Kumar Mehlotra from New Delhi, Dr. Sumita Sharma from New Delhi, Dr. Sanjeev Puri from Hoshiarpur, and Dr. Shantanu Kumar Bhattacharya from Kolkata. Thank you all the doctors to take part in our quiz. This today's session is brought to you by your zero calorie electrolyte drink in Nizal Zero. Now, before I give this session to our host, Dr. Sanjay Kalra, I would like to announce one thing that currently that the whole India is at the grip of World Cup. So next 3 weeks that we are taking a break because on 29th October that there is a match of India and England. On 5th November that there is a match of India and South Africa, and 12th November that there is a Diwali and the match of India and Netherlands as well. So for next 3 weeks that we will take a pause, but that we will come back with a bang again. So I would like to welcome our host, Dr. Sanjay Kalra. Over to you, sir.
Thank you, Ankur, and good evening, everybody. India is doing fairly well today. We are 186 for the loss of 4 wickets, and we are making steady progress. So, Jai Hind, everyone, and we hope that our boys win the match today. And of course, all their matches coming up. And since we
Yes,
want to
sir.
cheer for them, like Ankur said, we'll take a break for 3 weeks so that we can give full throated cheer and support to our boys as they fight for glory in the World Cup. And I'm sure Dr. Vedant Kulkarni, who has joined in, agrees with us. We'll talk today about thyroid and diabetes. And this is part of our recent series where we are speaking of the concept of glucocrinology. Let me share what glucocrinology is. Glucocrinology means that uh, we have glucose on one hand and endocrinology on the other. So, glucocrinology speaks of the interaction between glucose metabolism and various endocrine functions. Part of glucochronology would be unraveling the similarities or the links between pituitary and diabetes, for example. We did that last week. Today, we'll go one step below from the pituitary and hypothalamus. We move to the thyroid. So, we'll talk about the links between thyroid function or dysfunction and glucose metabolism. Now, the first thing to note is that thyroid dysfunction is very common in India. Diabetes is also very common. So, as it is, both can exist together. The percentage is so high. Thyroid dysfunction in India is usually autoimmune in nature, usually. Diabetes can be autoimmune in nature, like type 1 diabetes. So, therefore, because of autoimmunity as well, they can coexist. But the sheer number of patients with thyroid disease, the patients with type 2 diabetes, means that the coexistence can be just by chance. However, there are specific causal associations. First of all, we've mentioned autoimmune associations. Second is genetic. Many of us are predisposed to such diseases. The third is in autoimmunity, polyglandular autoimmune syndromes. So, polyglandular autoimmune syndromes means that there is an autoimmune disease which affects the pituitary, the parathyroid, and the pancreas, for example. Or it may affect the thyroid, the pancreas, that is type 1 diabetes, and maybe the gonads, premature ovarian insufficiency. So, these are various associations. Another one is more malignant, and that is called multiple endocrine neoplasia, where you have neoplasia or cancers of various endocrine tissues. So, this is one aspect of thyroid and diabetes being together. But a much more common aspect, something that all of us face in the OPD, is the phenotypic similarity. Patients may come in with similar symptoms: easy fatigability, tiredness, bagginess under the eyes. Patients will come and say, I've got dark circles under the eyes. Changes in appetite and weight going up without any rhyme or reason, maybe weight coming down without any rhyme or reason. Patient says, I have lost 20 kg. The first 4 or 5 kg that I lost, I thought it's because of my dieting, my exercise. But now I realize something is wrong with me. Please help me out. Too much of appetite, too little of appetite. These can be symptoms of thyroid disease. They can also be symptoms of diabetes. Another aspect is not only the symptoms, but also the phenotype, the metabolic phenotype. So the dhol, we've used this word many times. The metabolic syndrome means in India, the dhol or the drums of metabolic syndrome, like D for diabetes, dysglycemia, H for high blood pressure, O for obesity, L for lipids, dyslipidemia, L for liver, fatty liver. If somebody comes with dysglycemia, high BP, overweight or obesity, dyslipidemia, and fatty liver, it is possible the person has an underlying thyroid disease. So these similarities are there, and we should be aware of them in the OPD. Specifically, when you look at patients with complications of diabetes, the symptoms and signs of hypothyroidism are quite similar to those of diabetic kidney disease and diabetic heart disease. So hypothyroidism can predispose to heart failure. It can cause fluid overload, and the same things can occur in kidney disease and heart disease. So we should be aware of these similarities between diabetes and thyroid, between diabetes complications and thyroid. And that's why it's a good idea to screen all your patients. Anyone with symptoms or signs suggestive of renal impairment, heart impairment, of course, do renal and heart tests, but also do a TSH. A high TSH can cause heart failure. A low TSH can also cause heart failure. Kidney disease can be associated with very low TSH, normal TSH, or high TSH also. Similarly, in patients who are hypothyroid, you treat them and you realize that the symptoms are not getting corrected. Patients are still unhappy because the TSH is normal, because even though the TSH is normal, they are not normal. Don't hesitate to get other tests. You are diagnosed hypothyroidism. That may not be the cause of symptoms. The cause of symptoms may be A for anemia, B for vitamin B deficiency, or B for high body weight. It may be C for calcium deficiency, or D for diabetes. And it can also be E for exercise, lack of exercise, or maybe too much of E for ethanol in my part of the country. So, see, so many of links now coming up suddenly, and we realize that yes, there are patients in our OPD whom we think have thyroid disease, but may also have other metabolic disorders. Or there are patients in our OPD whom we know have diabetes, but they also may have thyroid dysfunction. Let us see why these links are there, and let us look at this beautiful table. Now, hypothyroid patients have slow body metabolism, lower energy expenditure, and this encourages weight gain. When they get weight gain, that leads to insulin resistance, which leads to high insulin levels. Obesity directly and the high insulin levels indirectly lead to hyperleptinemia. So, leptin levels go up. There is leptin resistance in obesity. Leptin increases TSH secretion. So, that's why TSH goes up. So, hypothyroidism leads to obesity, which in turn leads to high TSH secretion. So, it's a positive feedback circle. High TSH actually increases the differentiation of pre-adipocytes into adipocytes, and that again worsens adiposity, obesity. Obesity, in the meanwhile, also increases release of inflammatory cytokines, which reduce iodine uptake in the thyroid gland, and this also promotes hypothyroidism. So you see multiple ways in which hypothyroidism and obesity enhance each other. As a physician, what should be aware of? First of all, the epidemiology. Second, the biochemistry. And third, the fact that if you are testing a person during an acute illness, thyroid function tests may be impaired. T3 will come down first in anyone in acute illness. Then T4 will come down. and after that TSH also comes down. So you may miss borderline patients. What this means is you must do the test after the acute illness is over as well. Similarly, for diabetes related tests, you may do a glucose and it comes as 143. You say, no need to bother. But actually, patient is in ketosis. So it's a glucose of 143 and ketones are large or ketones are moderate. That means we have to treat the ketosis. If it is because of malnutrition, starvation, we treat that. But it may be because of diabetes as well. So we need to be aware of these facts. Secondly, in uncontrolled thyroid disorders, HbA1c becomes an unreliable marker. If you have a patient with a very high T3 and T4, that is Graves' disease, then the HbA1c may be lower than normal actually. Second thing that we should be aware of, apart from the epidemiology and the investigations, is medications. Now, metformin is known to reduce TSH. So, do not use metformin as an anti-thyroid drug. Do not use it to bring down TSH, but be aware that if you start metformin in a person with Hashimoto's thyroiditis, hypothyroidism, and type 2 diabetes, TSH may come down. Similarly, if suddenly the patient stops metformin for whatever reason, TSH may go up slightly. Methimazole can worsen glycemic control in very few patients, but usually what happens is that methimazole or carbimazole, they improve glycemic control, because in patients with uncontrolled Graves' disease, glucose levels are a bit higher because of faster metabolism. In patients with uncontrolled Hashimoto's thyroiditis, uncontrolled hypothyroidism, usually glucose levels are lower. And as the patient's TSH comes back to normal, as the patient begins feeling better, actually glucose levels worsen. Patient then comes and complains, Doc Saab, when I was hypothyroid, I was fine with life. I was a bit lazy, my TSH was 60, but I had no complaints, my glucose was perfect. Ever since you have started giving me thyroxine, my glucose levels have gone up. The reason is we tell them that now you've become more active, your body needs more food. And the analogy I use with my farming patients is, as your wheat crop grows, you need to give it more water, more fertilizer. It needs more air, more sunlight. That is how it grows. So now earlier you were hypothyroid. There was no fertilizer in you, no water, no air. Now that you've got the fertilizer, which is thyroxine, now you're growing up. So we need to give you more food and more insulin or more tablets to accompany that. For many of our patients, we use corticosteroids for a short period of time to treat thyrotoxicosis, to treat active thyroid eye disease. And these two can cause hyperglycemia. We should be aware. And newer uh, biologicals like rituximab are used in thyroid eye disease. These can also be associated with dysglycemia. Older sulfonylureas have been said to have a goitrogenic effect, but we don't see that in practice. Whatever modern sulfonylureas we have, glyclazide, glimepiride, we can use them safely. Pioglitazone, however, should be avoided in patients with orbital edema, thyroid eye disease, because it increases IGF-1, increases adipose tissue synthesis, and also increases TSH secretion. Liraglutide is contraindicated in persons with medullary thyroid carcinoma and also those with a family history of medullary thyroid carcinoma. Uh, and we follow this strictly in practice. But there are reports earlier of increased thyroid malignancy with older sulfonylureas and analogs. These are not of clinical relevance today. Beta blockers are relatively contraindicated in diabetes, but they are drugs of choice to manage tachycardia in thyrotoxicosis. Do not hesitate in using these drugs. They actually help the patient who is thyrotoxic, and you can use them for a short period of time. If you're afraid of using beta blockers, off label, you can use a drug called ivabradine. Ivabradine is a rate lowering drug, it reduces the heart rate, and it does not have any of the other disadvantages that beta blockers have. Now, let's talk directly about glucose control. Graves' disease is a common cause of refractory diabetes. Patient is not improving, you are giving the best possible drugs or insulins. Patient's weight is not coming up, glucose is not coming down. Look for other causes. The causes can be hyperpituitary. like acromegaly, Cushing's disease, hyperthyroid, like Graves' disease, and hyperadrenal, like Cushing syndrome. At the opposite end of the spectrum, unexplained hypoglycemia or sudden onset hypoglycemia. Hypothyroidism is a common culprit, so get a TSH done. Though very rarely you will find hypothyroid patients who have got extreme insulin resistance, but this recovers within a week or two. Uncontrolled diabetes also influences thyroid function. So patient comes back with the sudden changes in TSH, maybe from 0 going up till 50 or from 10 coming down to 1. Look for other causes. Don't forget to get a glucose done. So let's try to summarize what we are speaking about today. First sentence is we should be thyrovigilant in patients with diabetes. Second, we should be glucovigilant in patients with thyroid disease. So everyone with type 1 diabetes should get a TSH done in India. Everyone with type 1 diabetes should get a TSH done in India at least once a year, if not more. And if your patient is euthyroid and you're not expecting any change, once a year is fine. If your patient is on treatment, then you would obviously want to monitor more frequently, maybe every 3 months. Everyone with type 2 diabetes does not need screening, but maybe every 3 to 5 years as routine testing, you can do that. Or if the TSH has been documented to be higher earlier, or anti-TPO is detected, or maybe patient has a history of thyroid disease in the family, or patient has history of exposure to chemotherapy or surgery related to the neck, then we may want to test for hypothyroidism every year. This is thyrovigilance in diabetes. Glucovigilance in thyroid means that everyone with the sudden fluctuation or sudden change of thyroid function should get a glucose test done. Just rule out diabetes. But speaking of diabetes, let's come to our quiz questions now. So our first question is the prevalence of hyperthyroidism. Hyperthyroid is highest in type 2 diabetes, type 1 diabetes, general population, or all of the above. So A, type 1 diabetes, B, type 2 diabetes, C, the general population, and D, all of the above. Who has the highest prevalence of hyperthyroidism? Our second question is a bit of a googly, so listen to it carefully. Which test is commonly used to diagnose thyroid disorders in individuals with diabetes? So the question is, which test is commonly used to diagnose thyroid disorders? And the choices are A, HbA1c, B, fasting glucose, C, thyroid function test, and D, lipid profile. So, with these questions, we come to the end of today's talk, and let me take questions. So, and Jai Hind, Dr. Vedant Kulkarni. It's always nice being with you, and Dr. Vinayak Sharma and Dr. Manu Sharma as well. Hi to Vovo. It's a very interesting name that you have. For cough, Dr. Nitin Narula is not getting cured. So, the folk medicine that I would suggest would be mulati, which is licorice in English. You can try that. But if cough is continuing, then probably we are missing out on maybe asthma or something. There is something else going on. Dr. Nikhil has answered correctly. Thank you. And we have more questions as well. There is a question from Dr. Baban Tote from Amravati in Maharashtra. The answer is an emphatic yes. Can complications of type 2 diabetes be avoided if glucose metabolism is maintained to euglycemic levels? Yes. We can very confidently tell our patients that all the complications that we encounter are not because of diabetes, they are because of uncontrolled diabetes. And they are usually self induced. We ourselves create the complications by not taking therapy. So we can tell that very confidently. Dr. Nikhil Sathia from Pune asks current role of GLP-1 receptor analogs. These are now drug of choice in patients with the diabetes and obesity, with diabetes and heart disease. And also their role in preventing kidney disease has been highlighted recently. Oral semaglutide, Dr. Yogesh Russell is from Pune in Maharashtra. It can be used for weight loss in persons with diabetes as per label. As of now, it is not approved for use in non-diabetic patients, but you can use off-label, but you have to counsel your patient, you have to mention. We have other zero-day questions as well, and on the 19th of November, we will come back for lots and lots of questions and answers. Let's look at what the score is. So India not doing all that well now. Now we are 208. Oh no, it's fairly okay. 208 for the loss of 5 wickets in 37 overs. We still have 13 overs to go. New Zealand seems to be doing a tight batting, a tight bowling, but Ravindra Jadeja is batting at 9, and Virat Kohli is still unbeaten on 63. So hopefully they'll get us through to the victory podium. It's nice being with everyone, and I join everyone who is with us today and who is not with us to cheer for India. Two more questions. How is DAPA helpful in heart failure? So, multiple answers. First of all, it causes diuresis. That is the simplest answer. But secondly, it improves the bioenergetics in the mitochondria of the heart. So, it improves the efficiency of pumping of the heart muscle. It also reduces the post load and the preload. So the heart muscle becomes more efficient, and it also has to work against less preload. It has to work to handle less preload, and it has to work against less post load. So at all three levels it acts. Dr. Manu Sharma says, how do I differentiate between Graves' disease and subacute thyroiditis? Okay, so the simplest answer would be to send patient to nuclear medicine for a scan, but many times in practice it's not possible. If patient has had low TSH for about 6 months, chances of subacute thyroiditis are out. Subacute thyroiditis will last for few weeks at the most. Patient will come with severe neck pain. Symptom will be neck pain. ESR will be high. CRP will be high. So CRP will be very high. You can do a therapeutic trial. You can give a course of steroids and keep on checking CRP every 5 to 7 days. If the CRP falls markedly, that is subacute thyroiditis. Now, it can be Graves' disease also. In Graves' disease, the TSH will remain low, T3, T4 will remain high, and the disease is not going to change within weeks. So these are some ways to differentiate between subacute thyroiditis and Graves. Some unique factors about subacute thyroiditis. We have seen it occurring commonly in colleagues in orthopedics and in cardiology, in nursing as well. These are people who are exposed to radiation from C-arm. So you should take that history as well, exposure to radiation. And thank you, Ovaji, for your kind words. With this, I'd like to thank everyone for having been with us today on a very special day. And I'd like to welcome Mr. Basu to the forum.
I think Sir has already announced that next 3 weeks we will be taking off from our journey with Dr. Sanjay Kalra in our diabetes essential because we internally discussed and found that we India is going to have three big matches on 29th October versus England, 5th November versus South Africa, and on 12th. Actually, we are into Diwali period as well. So we genuinely feel that many of our viewers will not be able to find time out to be attending our sessions on these dates. So we thought on from their behalf as well as from our regular viewers behalf that we need to take 3 days off because there are two big occasions colliding together, festive season as well as fever season together. So this is a big announcement. I think next 3 weeks we will not be available, and on 19th November, we will be coming back once again from the same continuity with Dr. Sanjay Kalra, taking on the currents where he is already talking about the endocrinology into mainstream with diabetes essential. So he will be taking on from the same session which we have discussed today, thyroids and diabetes impact. With this, I sincerely thank Dr. Sanjay Kalra and our viewers. uh, Today is eighth day of Navratri, and in West Bengal today is Mahaastami. Wishing all our viewers Subho Astami as well as happy Navratri. Coming week we will be having Dasera, and we will be also won't be there on air live for Diwali. I wish everybody a very happy and prosperous Diwali and Dasera. In future, I would like Sanjay sir to also wish viewers and doctors happy Diwali and happy because they all will be waiting for your wishes, sir.
Wishing everyone a happy Diwali in advance.
Thank you, sir. Thank you, sir. With this, I sincerely thank Sanjay sir being with us and continuing the journey on the third year of Diabetes Essential. We'll be back on 19th of November post Diwali. Good day, Jai Hind, Jai Hind, sir.
Jai Hind. Jai Hind.